Good evening, everyone. Thank you for joining us tonight. Welcome to the Avexia webinar series. Our topic for tonight is Pharmacogenomics in My Practice. Is it worth the hype? My name is Christopher Chu. I am the Director of Marketing for Avexia Diagnostics and will be your host for this evening. Today, I have the distinct pleasure of being joined by our guest, Dr. Erika Gray, co-founder and Chief Medical Officer at Toolbox Genomics, who will be our presenter for this webinar. Dr. Gray is a UCSF trained pharmacist, educator, national speaker, and co-founder and chief medical officer of Toolbox Genomics and My Toolbox Genomics, a digital platform that takes an individual's genetic test results and offers a virtual toolbox of informative, user-friendly lifestyle choices and action plans to live the healthiest possible life. With almost 2 decades of experience in the world of functional medicine and a decade of experience in genomics and pharmacy, Dr. Gray is dedicated to helping practitioners and individuals understand the intersection of their unique genetics with the environment and how they can positively change their health trajectory. Joining Dr. Gray tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Avexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, we would just do a bit of housekeeping. We encourage participation, so if you have a question, you may submit your questions in the questions field in the right-hand area of the interface. We will answer the submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. Without further delay, I will now turn the webinar over to Dr. Gray.
Thank you so much for having me, Chris. Hello, everyone, and welcome to this evening's webinar. I'm going to go ahead and turn off my camera here, if you don't mind, just because it's crowding my screen. So I apologize. I'll show my face intermittently here. Let's see. There we go. So pharmacogenomics in my practice, is it worth the hype? And I put this up here because I wanted to give you a little bit of context about pharmacogenomics and what the promise that it has held and kind of where we have been and where we have gone. If you can believe it, pharmacogenomics has actually, the study of it has been around since the 70s. And I just want to let that sink in for a second, because when I read that, and it might even be the 60s, I was absolutely stunned, because when it was presented to me in pharmacy school, it was presented in such a way like, this is the new thing, it's going to revolutionize medicine, it's going to be absolutely incredible. And then it was just like crickets. Nothing happened. And I was always trying to grapple with, this is so fascinating. Clearly, this is really promising. But what is the other part of this? Why aren't we seeing this come to fruition? So I hope that by the end of this webinar, you will have a greater appreciation for what pharmacogenomics truly can do, how it can help you in your practice, and how I think it is really one of the aspects of DNA testing that does deliver on the promise of DNA testing. So let me go. Oh, there we go. So I wanted to start with just a little bit of background that's really starting to come to the head, because it is not something that I was hearing about during pharmacy school, and I thought that this was really, really fascinating. So this is of July 16th of this year, and this is just a quick little blurb from a newspaper article. But the Oregon Health System settles a chemotherapy death lawsuit, and they agreed to pay $1 million to the widow of a cancer patient who allegedly died of a toxic reaction to a chemotherapy drug due to a genetic variant that affects 8% of the population. Point being, if they had done this DPD type of testing, they would have identified that her husband was at a higher risk for toxicity and actually would have required a lower dose of capecitabine. So we're starting to see some repercussions if we don't do pharmacogenomic testing. And I don't put this out here to scare you or to worry any of our attendees, but really just to bring shine the spotlight that there are tools out there that can help you be a more efficient clinician that is going to help not only you, but also your patients. Additionally, there's the Right Drug Dose Now Act that is being explored in Congress. And what they are going to do is they're actually updating the National Action Plan for Adverse Drug Prevention. And they're adding educational information on how adverse drug events can be reduced with the use of pharmacogenetic testing. And they are pushing to update electronic health records with pharmacogenomic information so healthcare providers can better understand the link between genetics and drug metabolism when prescribing. And really, that enables us to prescribe with a personalized medicine focus. It allows us to really take a look at what is unique to my patient and what do they need. And I think it's important just to highlight that, even as a pharmacist, I still think that medications are an excellent adjunct at the right place at the right time. I think there's definitely other modalities that should be explored or used in conjunction with medications. But going back to the Right Drug Dose Now Act, the fact is Congress is now realizing that we need to be doing a lot more around pharmacogenomics, and it is at the forefront of their mind. So let's get a little bit of nomenclature, because is it genomics? Is it genetics? Well, they're both, you can use them both. Really, we should be calling it pharmacogenetics, because we are actually interested in the role of genetic variation on the response of the drug. However, what it is commonly called is pharmacogenomics, where we're looking at the components of the genome. So that's really a much bigger picture. We're actually really focusing on the genetics because we are looking at specific DNA polymorphisms or coding variants versus epigenetic or transcriptomic changes across the genome. So bottom line, we call it genomics. We should be calling it genetics. I don't think it's going to change. So one of the things that we find is adverse drug reactions are one of the top leading causes of death. 500,000 adverse drug reactions, costs over $150 billion a year. 30% of these ADRs could be preventable if we had done a pharmacogenomic test on our patients. Now, there's many components that lead to a drug response. So it is not all genetics. I just want to remind people: gender, race, ethnicity, disease state, organ dysfunction. What about nurture? Do you smoke? Do you consume alcohol? What kind of diet are you eating? What type of other medications are your patients taking? And then lastly, we cannot forget the importance of physiological changes, especially in pregnancy, lactation, and then of course, if we are aging. So I like to think about genetics as the way we set the scene for our story, the play of our life. And if you think about it, when you set up a stage, your I forget the term, but they're going to set a door here, and they're going to put a window here, and they're going to essentially set the pieces of furniture that cannot be moved. They're going to put that onto the stage, excuse me. That is your DNA. However, how you choose to decorate, where you put the couch, what kinds of curtains do you do, that is all in your control. I should be saying your patient's control, or perhaps you're interested in this personally. And there's a lot of things that you can do with it. So I just want to remind people that there is latitude. So if even though you may have a gene which codes for a particular enzyme, which may lead to a change in the way we metabolize a particular medication, there may be other components to it. And so I just want to make sure that people don't lose sight of these other factors that could be playing into this. Now, what happens if you have some variants which lead to changes in enzyme, changes in transportation, or the lack of activation of your prodrug into the active drug? Well, we could have toxicity, adverse drug reactions. We might get a longer half-life. We might get a shorter half-life, which means that the dose may be more effective or less effective. We get those drug-drug interactions that could be exacerbated. As I mentioned earlier, decrease in prodrug activation or decrease in drug efficacy. There's two important components to pharmacogenomics that I think are important to highlight. So there's the kinetics and then there's the dynamics of it. So the dynamics is really this transport. Where is it going? How is it getting there? Versus the kinetics is how are we taking it apart? So the taking it apart are our CYP enzymes. And so that's really where the big focus of pharmacogenomics is. However, SLC, ABC, these are our transporters that are moving the drug metabolites around. And depending on how well we move our drug metabolites around and how efficiently we can excrete them, that may also play a role within how we handle different medications. And so this is where investigating like serotonin transporters, COMT, COMT, those are some of those examples of what we would call non-drug pharmacogenetics. So just as a quick reminder, when we're talking about these variants, we're talking about a single nucleotide polymorphism. This is affectionately called as a SNP. So as you can see on this one image over here too, I think it's going to be on your right, you can have a C typically goes with G, A typically goes with T. Now, what can happen is over the process of time, and there's nothing wrong with SNPs. We need SNPs. It is what makes us so diverse and unique. So you may end up with a C and a T at a particular location at a chromosome. And if that's the case, it may code for a slightly different enzyme. You may get an altered shape. And if your enzyme has a different shape, it's going to have an altered function and it can't do its job. So most of the SIPs that we talk about are shown here. And I just want to highlight that within the human liver, 3A4, 2D6, the CYP2Cs are really important. Now, 2D6, I just want to highlight here, is actually 2% in our liver. But then take a look at how much it contributes to drug metabolism. I find it absolutely fascinating. So 3A4, sorry, I should just say the CYP3As and then the 2D6 category, those are really the focus of pharmacogenetic testing. Now, how does all of this nomenclature actually work? Because I'm throwing these around. And I also want to highlight the star allele, and I'll get to that in a second. So the CYP stands for cytochrome P450. 2 is the enzyme family, D is the subfamily, the number 6 is the gene, and then it gets into the allele. Now, these star alleles are tricky to test for. The sequences that you have to look for within the arrays for the results are not always the most straightforward. So please, 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 if you do pharmacogenomic testing, you want to choose a company that is using a pharmacogenomic specific array. I cannot tell you how many arrays I have looked at with different companies, and when we get to the star alleles, we hit a roadblock because they need to actually be able to give you the entire complement. They have to go from a poor metabolizer all the way up to a fast metabolizer. And if they don't have the ability to test for all of those star alleles, you can't accurately comment on an individual's metabolism. This is specifically around 2D6. So just a little bit of commentary about that. So this is what we typically see. So I'm focusing over here on my right, so probably your left, is you get this cohort of individuals. They all have the same diagnosis. And then as clinicians, this is what we see. Some no benefit, no toxicity, benefit, no toxicity, benefit and toxicity, and then no benefit and toxicity. And so that gentleman that we talked about earlier, he's somewhere in this no benefit and toxicity. Maybe he benefited in toxicity, but ultimately he ended up, passing away. So really, today's method is full of trial and error. It is time and money exhaustive. So for example, an antidepressant can take 6 to 8 weeks to take full effect. And if we're choosing the wrong antidepressant, we're now actually potentially delaying how long it takes our patient to get a relief. And it's frustrating because the current guidelines don't incorporate pharmacogenomic testing, and it's all written with the same lens of, here are these patients with this diagnosis, ergo, this is what we can give them. So in contrast, if you notice over here on this figure 3, you can see how many different classes of different drugs are actually ineffective for certain individuals. And pharmacogenomic testing is going to help you tease that out and be much more laser focused in your selection. So here's what will happen is, depending on what type of metabolizer they are, you can see this, you have a huge range of drug response. And if the success of the medication is dictated by how well or how good of a Cmax or a drug response you get, you can see where this is actually going to be a potential problem for a lot of people. So for example, poor metabolizers are considered to have lost the function of 2 alleles. So remember when we were talking about C's and G's, each, like the letter C and the letter G, each correspond with an allele. So they have essentially lost all the function. If we go all the way up to the ultra rapid metabolizers, they actually have duplications. So they have more copies of those alleles, which enable them to really rapidly break down those medications. And so again, because there's this duplication part, that's why checking on these star alleles can be really difficult. And just to give a highlight of what you can see with antidepressants and antipsychotics, and this is focusing on CYP2C19, you can see what happens from this enzyme capacity. It goes anywhere from 0% all the way up to 120%. And so essentially anytime you have a null allele, so this is a loss of function, then you're going to have a decrease in enzyme capacity or transcription levels compared to that of normal alleles. You may not completely lack the enzyme, but it's more that the enzyme can't do its job. It doesn't work as well. In contrast, if you have the variants, and for the normal or the ultra rapid, you tend to have an increase in enzyme capacity or transcription levels. And so what a lot of literature is finding is that specifically CYP2C19 and 2D6 are incredibly helpful genes to investigate around antipsychotics and antidepressants, because these are the genes that were consistently found to influence pharmacotherapy response in 7 different randomized controlled trials when they looked at it prospectively. So that's a pretty significant number. And there is lots of literature out there looking at the role of pharmacogenomic testing, especially in the role of depression. So for this particular trial, they looked at individuals who were either randomized to pharmacogenomic guided therapy or they were just a control group. And what they found was that there were better responders in the pharmacogenomic group versus the control at the 12 weeks. And the ones with the pharmacogenomic guided dosing, they had a sustained response. And that was after they went through and they did multiple testing corrections. So it's really interesting because initially there was no difference at the 4 and 8 week point. But as we were talking about how long it can take for an antidepressant to take effect, it was at the 12-week mark that they really saw that difference and the benefit of choosing a pharmacogenomic guided therapy versus not. So I just think that's really, really powerful information on that. And then here again was just another study where they were looking at it, and the individuals who had the pharmacogenomic were in the pharmacogenomic arm had greater symptom approval. That was 27% versus 22%. Better response 30% versus 22, and the remission rate, this was the part that was really interesting, was almost 16% versus 8%, so almost double. And it was really, really significant. And at the end, their conclusion was that the results from this trial indicate that a combinatorial pharmacogenomic testing can be an effective tool to help guide depression treatment in Canada. Well, what about the elderly? So in general, anybody who is over the age of, I think it's about 65, takes an average of 8 medications, which is a staggering number because that's the average. So that means there's a whole bunch of people who are taking a whole lot more. And yes, there are people who are taking less than 8. But really, really important to recognize the power or the dangers of polypharmacy, and again, ensuring that we're not starting to have toxicity, or that we're having somebody who's a poor responder, and because the practitioner doesn't know they're a poor responder, then the practitioner adds on yet another medication, and then potentially we have a drug-drug interaction. And so in this observational study, they went through and they looked at 205 patients, and they found that there was an overall improvement of 72% in the group that had the testing versus 49%. They had a potential cost savings of $218, and that was an average. The provider majority, 95%, considered the test helpful, and 46% of the providers did follow the provided recommendations, and they found a significant improvement, especially in hospitalization rate, ER visits, and then how many times they came back to their practitioner complaining of a lack of improvement. So just to really help remind us of a couple medications that are very, very commonly prescribed and why they may not actually be working. Clopidogrel, so that's a prodrug. Here's our friend CYP2C19 is back. And so again, if you are, quote, a poor metabolizer, you can see the star variant there, and they have a loss of function. You don't get the active metabolite, which is designed to inhibit the platelet aggregation, and we are actually increasing their chance of a cardiovascular event. So to me, everybody who's put on clopidogrel, and remember, most people who receive a stent receive a year of clopidogrel. That is the standard. But if we're giving them a dose that's not working, that's not going to help prevent a potential readmission. Tramadol is another one. So here's our friend 2D6. And with tramadol, again, this is an analgesic. And so in order for it to work, you have to take the parent drug and make that conversion. And only when that happens will you actually get the benefit. And what's interesting is that you need this M1 metabolite That's what helps with the analgesia. If you're an intermediate, that's what I am, and a poor metabolizer, PM, if you're either one of those, you don't get the M1 metabolite. And if you don't get that M1 metabolite, you're not going to get the pain control. And tramadol is a medication that I think a lot of practitioners often will reach for because it's kind of like a quasi opioid. It's not, it doesn't feel as hard hitting as something like oxycodone or hydromorphone. And so that's why tramadol is often given, and it's often given to the elderly. So again, all the more reason to really understand how it's being utilized in the body and what people need to be aware of with their metabolism status. So just as a quick overview, there's many different companies out there doing pharmacogenomics, and everybody has a little bit of a different focus. They've interpretations range. So Coriell and translational software have essentially been blessed by the FDA, and they leverage the FDA guidelines as well as the CPIC guidelines. And these are guidelines that you can find online. You just simply Google them. And what they do is they list the medication, and then they list if there should be an adjustment from a pharmacogenetic perspective. So it's very clear there. You always want to use a CLIA and CAP certified company. I think it is sometimes when you're trying to decide what type of company we want to work with. That's just a certification. It's really easy to find. Anybody who uses that, they're going to either put it onto the report, or of course you can just call them and you can ask them about their CLIA or CAP certification. And I wanted to give you a couple examples of some other companies out there. Quest is also a company that does pharmacogenetic testing. And on here, you can see as you go further down, like MTHFR, OPRM1, this is how pharmacogenomic testing was done in its infancy. And I'm not trying to pick on Quest, but I'm just trying to help you figure out what type of company you want to work with, and how to best utilize the information. So you can see here, they tell you what the genotype is, they tell you what the phenotype is. What is the result? Reduced MTHFR activity, a normal metabolizer. But clinicians really need that next step. So what? If I'm a normal metabolizer, what does that mean for these particular medications? And so I think that's just an important thing to keep track of, so that you can be much more efficient with your patients. And I think it is reports like these where people feel frustrated with genetic testing or pharmacogenomic testing because the so what piece is missing. And that's the part that is just absolutely critical for us to be efficient clinicians with our patients. And then here's just a quick overview. Insurance is very much all over the board. There are some insurance companies that do cover pharmacogenomic testing. Others only cover it around ADHD medications. Others cover it if you have had treatment failure. So you can see it's the gamut is there. What I have been told by some different people in the industry is that it really does depend on the biller and how they code the reason for the visit and why the patient needs the pharmacogenomic test. So I hope that you can see that there's all kinds of great things that you can do and learn with pharmacogenomic testing. However, there are limitations to it. And so I get really excited with genetic testing because I just think there's so many amazing things that you can do with it. However, as my husband always likes to say, yes, but it can't be perfect. Like it can't always be the answer to everything. And so I just want to highlight a few of these. So nutrient sufficiency is often key for medication success, and we're going to touch upon an example of that. Pharmacogenomics only tells one part of that story. So as I had mentioned earlier, what type of life have you lived? Or how old are you? The nature versus nurture, the pregnancy part, the aging. It's what type of kidney function do you have? Because if your kidneys aren't working optimally or your liver isn't working optimally and you have some of these variants, your perception or your benefit of pharmacogenomic testing might be very different from somebody else. And we just also can't forget the role of other genes. It is so easy to say, I have this gene or my patient has this gene and I have this is the situation or the problem, and this is what I'm going to do about it. But remember, genes don't work in a vacuum. They all work together. And so we just can't forget that there's millions of other genes that are on the block that also play a role in this. So here is just an example. I'm not endorsing Deplin. This is just I think a really great example of how you can leverage an L-methylfolate, 5-methyl tetrahydrofolate as an adjunct to help with somebody who might have had some treatment failure or maybe a suboptimal response to SSRIs or SNRIs. And so if you think about it, there's a bunch of literature that just came out and said, well, low serotonin doesn't necessarily lead to depression. And it seemed to be earth-shattering for a lot of clinicians. But let's remember, folate is really important for us to make SAMe. Folate is really important for recycling homocysteine back into methionine, and homocysteine is inflammatory. It can be inflammatory for our brain. So it is distinctly possible that for some of our more complex patients, we need to also look at that nutritional component. And so that's why I put that here, because you just never know. And for individuals that they studied who did receive the L-methylfolate or even folinic acid, they found that they had improvements on their depression scale scores, patient response, and remission rate. So there you go. And again, we know that there's other genes that play a role with folate, with recycling homocysteine, specifically B12. So I just want to try to put this all into some context for all of you to understand how this may all come together. So I've got a couple cases here just to really highlight some ways that you can leverage pharmacogenomics. So we've got a female here with depression, a little bit of anxiety. She's already tried 2 SSRIs. She is mildly obese, having difficulty losing weight, and she's on Synthroid. So let's take a look at her genes. And what we're finding here is that, well, it turns out that her sertraline and escitalopram, those are fine. We really don't need to, those do not seem to be contributing to her worsening depression. However, she did test positive, so to speak, for the variant in a couple other genes. So we know that MTHFR changes our folate levels, increases homocysteine levels. So that may be contributing to this. And so for her, giving her a little of that L-methylfolate or switching her to that form could be really beneficial. MC4R is one of these pharmacodynamic genes, but it also has to do with snacking. Individuals with this, they tend to graze and they tend to just grab food if it's available to them. So I highlight that because, again, she's mildly obese. She's worried about weight gain. We know she has some thyroid issues already going on. And this may also be contributing to, when patients have increased weight, they tend to be harder on themselves. It may also be exacerbating the depression for her. Also for her, the SLC is a serotonin transporter. So she seems to be able to deliver the serotonin where it needs to go, but maybe we just need to help it in a couple other areas. And the thing to highlight on the sertraline or on the escitalopram is those from a pharmacogenetic perspective are fine. So we don't necessarily need to reach for another medication, but maybe we need to look at some other genes and look at the environment that she's living in, or what she's eating, or how she's living, because that may actually be the contributor to the lack of success, so to speak, or the perceived lack of success. So here we've got another individual, poorly controlled diabetes, hypertension, previous history of a TBI, hyperlipidemia, and now he's got a DVT. This is a pretty classic picture. He's on a lovely cascade of many different medications, and now he's got the memory loss and muscle pain, and he doesn't have much motivation, which I think is important. So one of the things that's interesting to note is phenytoin is a nastier drug because it does reduce the anticoagulation effects of your DOACs. And it also is going to be potentially have drug interactions as well. So it can be an inducer. So it would be great if we can think about putting him on Xarletto, apixaban, but we can't put him on Xarletto because of his fall and a drug interaction with phenytoin. So again, this will help us pick out what is going to be the better anticoagulant for him to ensure that he's going to have better success. The other thing I wanted to highlight here is for him, metformin, he might have increased drug efficacy. Now, there's this little note down here. So it says FDA drug label not established for PGX. So all that is saying is that the amount of information that is out there about metformin does not lead the FDA to say, yes, absolutely, this should have a drug adjustment. However, you as the clinician may want to take a closer look at his kidney function, at his B12 levels, because he might actually have greater drug efficacy. Now, phenytoin seems to be fine for him, but as we were talking about earlier, he was complaining of increased memory loss and of muscle pain, and he was also put on to atorvastatin. And atorvastatin is one that we want to go with caution for him. So he might benefit from a switch to simvastatin. Three other points actually. He also tested positive for Lp(a). So that is the lipoprotein A. It's a highly atherosclerotic form of LDL, highly prone to oxidation. So this would be another thing for us to investigate. He's also an APOE3/4. So individuals who carry the 4 allele don't always have the best response to statins. So maybe we want to actually look at some other modalities of lowering and improving his cholesterol levels and making sure he gets some CoQ10 in there as well. And BDNF is a gene that I love because individuals who have the variants for it tend to lack motivation. It's much harder to get them out and exercising. They tend to be couch potatoes. You really need to give them little baby steps to kind of get them out the door or get them to their next goal and really make them very small. But actually, like a little bit of exercise, a 20-minute walk, some fish oil, all of those are great for improving BDNF levels, and it's also going to really help the brain as well. So here's a quick thing on the sources, and now I get to hand it back to Chris.
Okay, that was fascinating, Dr. Gray. So basically now we're gonna do, if you could go back one slide, that'd be awesome.
Sure.
Yeah. We're going to take any questions. Dr. Sedano, what did you deem from Dr. Gray's presentation?
Yeah, Dr. Gray, that was fantastic. We have a lot of clinicians that use a lot of nutraceuticals, and I guess I like to pick your brain here just for a moment and talk about these nutrient inducers and inhibitors. Like an example, we have I know a lot of our clinicians prescribe DIM for metabolism of the estrogens and at high doses. And What's your opinion on, and just your thoughts on essentially megadosing if the patient is on pharmaceuticals? What's your take on that?
I think we have to tread with a certain amount of caution. So I get worried about taking high doses when we are modulating at the receptor level. So especially if anyone is on tamoxifen, raloxifene, or they're taking black cohosh, I think it's always important to remember how these different nutraceuticals work together. This is where I think a Dutch test is fabulous, because you can see where are the pathways that are affected. You can see what's going on with 3A4, 1A2, 1A1, and then you can put it against a pharmacogenomic test and say, okay, what do we need to improve? Do we need more of the enzyme to improve this particular pathway and send the estrogens down, more towards the 2-hydroxy or the 4-hydroxy and away from the 16-hydroxy? But I think, and I will say that I think there's great benefits for megadoses. I think it's important to know what you're targeting and why.
Yeah, that's what I was kind of getting at, and I appreciate that. Just to match a test like you're offering with, so patients and clinicians can actually understand that using caution with megadosing of nutraceuticals on how it affects these pathways, particularly on individuals with that are on pharmaceuticals. So this is again a wonderful test, and I appreciate that. Is it basically fair to say, just to sum up for the pharmacogenomics, is essentially that it's the individual's response to a drug just based on their genes? Does that make sense?
Yes,
Yeah.
that's exactly correct. And I forgot to mention in the presentation, it's just a buccal swab. So it's not a blood test. So if you have any elderly patients who are hard stick, it's just a cheek swab.
Yeah, that's great. Thank you so much.
Sure.
Thank you. So at this time, anyone have any additional questions here? We'll open up for a minute or so. Any submitted questions? Let's see here. Okay, well, apparently, Dr. Gray, you did such a great job. Everyone knows what the deal is. So if you don't mind going to the next slide, that'd be great.
Sure. Oops, let me click in here. There you go.
Okay, so right now I'm going to introduce the Ask the Doctor feature for our Avexia clinician accounts. It's a free service to all of our clients. Dr. Wayne Sedano, who you just heard, our Director of Clinical Support and Education, will review test results, clinical conditions, any questions you have about the tests offered by us. The service is by email, but as the doctor will attest to, he usually gets back to you way within 24 hours, if not sooner. And
Sorry, Chris.
oh no problem. But additionally, we also have a live consultation for a small additional fee. So check that out. You just go log into your Avexia account. On the left side, you'll see a Ask the Doctor banner. Click on that, and you'll have both options. Dr. Gray, if you don't mind proceeding to the next slide. Thank you. And now, now that we've learned so much about pharmacogenomics, I would like to review how to order the testing before we conclude the webinar. Step 1, log into your Avexia Diagnostics account and click the Avexia link Lab Orders. And then step 2, select your patient or create a new patient. Then click Add New Lab Order. Step 3, select Specialty Testing, and then click the Add Toolbox Genomic Products to the order. Use the search box to locate the desired test. Add it by clicking the blue plus symbol. And then step 5, click preview your order, make any edits you need, and then agree to the terms and conditions and place your order. It's just that simple. Dr. Gray, if you wouldn't mind, the next slide, please. Thank you. For any questions or issues you may have, contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. A recording of this webinar will be available by email in the next few days. Next slide, please. So I'd just like to thank Dr. Gray and Dr. Sound for this informative presentation. That was really amazing. And thank you all again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Toolbox Genomics, stay healthy, stay safe, and wish you all the best on your pathway to wellness. Thank you.
Thanks, everyone.
Great. Thank you so much.